I'm so excited to be here today to talk about LDN. We have so many uses for this, and I have seen it do so many amazing things with our practice and our clients. So I am excited to share with you some of the research that is available right now and how it's being used in chronic illness. So I am going to share my screen here. Hold on a second. As soon as I figure out, where did my slide go? Hold tight. There we go. There. Little technology stuff, right? Okay. Here we are. And then I'm just going to put this into a presenter's view so you can see the whole screen here. I should have started it from the very beginning. Sorry about this, guys. All right, so LDN is, as you guys have been hearing all day, an amazing product that's been brought to us and available to us for chronic illness. LDN has been used more widely now than it was even just 5 or 10 years ago when we really started to understand it and start to use it. So today what I'd like to do is talk to you about how it's used in chronic illness and what we're seeing in the research and different illnesses or disorders that you can use it in, and then present a couple of newer ideas of how LDN can be used as well. So just a little review in case you haven't heard all the other presentations earlier, and I would really recommend that you go back and listen to some of them where they talk about in depth what LDN is, but I'm just going to give you a little synopsis here. So naltrexone is an opioid antagonist. This means that it's meant to bind to the opioid receptors in the body that would traditionally block medications or drugs that bind to that receptor. So basically in the traditional world, we use naltrexone to help people that are addicted to narcotics or opioids get off of them. This prevents them from getting that ability to be high from them. In the low dose world, though, it's much different. So low dose naltrexone, also known for LDN, is a much lower dose than the traditional naltrexone. It's compounded by a reliable pharmacist specifically for each patient. And we can make doses very, very low. I've had Monica and her team make me doses as little as 0.25. So we can go very, very small and microdose if people are sensitive to LDN. The average dose that you're going to see somebody use low dose naltrexone in is about 3.5 to 4.5 milligrams. On occasion, we will go a little bit higher, and I'll talk about where that has been effective for us. The lower doses of naltrexone actually help the body to combat chronic illness and illness states. In low dose naltrexone or LDN, this helps the body in chronic illness states by reducing the inflammation in the brain that's caused by an overactive microglial. Microglial cells are a type of glial cells that affect the central nervous system in the brain and the spinal cord. It's a very important line of defense for us in immune function as well. When there's a chronic assault on the central nervous system, those microglial cells are activated and they release inflammatory substances called cytokines. And it's the cytokines that come in to destroy our foreign invaders. They come to help us. However, if the body is constantly on a reaction, on a repeated injury like infection or exposed to toxins, maybe trauma or emotional blows, the body can remain in a hyperactive state, keeping the brain in that chronic inflammatory state. And when these cells get turned on, they produce a pro-inflammatory cytokine response and a reactive oxygen species, or what we call free radicals and nitric oxide, all of which are capable of tweaking the nerves that produce pain, fatigue, and a whole host of other symptoms. LDN can also cause an adaptive increase in endorphin and enkephalin production chemicals in the body that make us feel less pain. So when these molecules work on the opioid receptors, they actually produce like an analgesic pain relief, much like Tylenol or Aleve or ibuprofen, without giving you the negative side effects of those medications in hurting the liver, disrupting the stomach, all of those kinds of things. They help to actually increase the endorphins to help normalize our immune response as well. So these are a few conditions that we see low-dose naltrexone treating. And the research is very clear on a lot of these. So autoimmune conditions such as MS, Hashimoto's, psoriatic arthritis, any of those kind of autoimmune responses, or even in those cases where somebody would have a positive ANA, but they don't really know what part of the body seems to be attacked, LDN can really come in and help with those kinds of things. We use it a lot in our practice for Lyme disease and other chronic viral infections, Epstein-Barr virus, cytomegalovirus, mold biotoxin illness. It's commonly prescribed for mold biotoxin, also can be prescribed for allergies, chronic fatigue syndrome, small intestinal bowel overgrowth, or SIBO that most people recognize that name. Certainly joint pain, nerve pain, dysautonomia or POTS, depression, headaches, leaky gut syndrome. There's just a whole host of symptoms that we can use this for. We can use it for traumatic brain injury, and I would love to see us using it at the onset of that traumatic brain injury to really help reduce that inflammation in the brain. We see it used in cancer patients, Sjogren's disease, autism, even something as simple as dry eye. It can be very helpful in those conditions as well. So research in LDN provides a lot of benefits for brain health. It helps to enhance the function of the endorphins like we had talked about. It balances our thymus gland to protect with Th1 and Th2 balance. So our thymus gland sits in the middle of our chest, and as we age, that thymus gland shrinks and doesn't provide us as good of an immune response as it did when we were younger. That's oftentimes why we see the elderly population have more detrimental effects of flu and other viruses and infections come winter, because they just don't produce that thymic production like they should. LDN can really be supportive in that. When we talk about Th1 and Th2 dominance, we're primarily talking about thyroid and adrenal function as well. That's what's commonly talked about, but it can be presented in many other places of chronic disease as well. It helps with inflammation. It helps produce the inflammatory cytokines, and it plays a role in the production of creating new cells for us as well. In autoimmune conditions like psoriatic arthritis, we suppress the glial cells, and therefore that's how it actually reduces the inflammation. And other conditions that we can treat, multiple sclerosis, I already talked about Hashimoto's a little bit, rheumatoid arthritis, lupus, ulcerative colitis, Crohn's, IBS, IBD, eczema, psoriasis, all of these things are considered an autoimmune condition that can be treated with LDN. So I want to talk a little bit about Lyme disease. In the Midwest, Lyme disease is very prevalent. It's a huge part of our practice. It is worldwide, despite what some people would like to talk about. You can have a persistent low-grade infection with Borrelia, which is the bacteria that causes Lyme disease. Many of the symptoms associated with chronic Lyme disease are due to a persistent immune response, not directly from the bacteria. So in the past, where we used to think that it was all bacterial driven, what we're finding in a lot of people who've been suffering from Lyme disease for 10 or 15 years is that it's actually an immune response, not necessarily that direct assault of an acute bacterial infection. So when we have inflammatory cytokines like IL-6, TNF-alpha, TGF-beta, these are typically things we see elevated in Lyme disease patients. When we treat Lyme disease and co-infections and add low-dose naltrexone in, it actually reduces these cytokines and the associated inflammation that is occurring because of them being high. When I'm working with a Lyme patient, I'll typically start out at a very low dose, somewhere between 0.5 and 1 milligram of LDN. Do it in the evening predominantly if you can. If it really disrupts your sleep, we'll have people move it earlier in the day, but then they gradually increase over a course of several weeks. And the reason we do that with Lyme patients is because LDN has been found in some cases to cause a Herxheimer reaction or a die-off reaction in Lyme patients, where you kill off more bacteria quicker than your body can get it out, and you'll have a negative effect with an increase of your Lyme symptoms as a result. And when we go slower, we don't see that happen quite so much. Our average dose for Lyme patients is about 3.5 to 4.5 milligrams a day. Mold illness, a lot of people are unfamiliar with this, but you can have mold biotoxins that are in your body from living or working in a building that had water damage, and you have mold present. Now, the hard thing with mold illness is that you don't always see visible mold, but the building can still be toxic. A lot of our school buildings that are very old have mold in them. People who grow up in old farmhouses with dirt crawl spaces typically have a lot of mold. And the more layers of infection or problems that you add on the body, the more this starts to come to the forefront. And there are ways to test to see if you have mold biotoxins in your body, but these are several symptoms that you'll see with people with mold biotoxin illness, and they can overlap with fibromyalgia, chronic fatigue, and Lyme disease symptoms as well. So you can have things like fatigue and joint pain, muscle pain, unusual headaches that you can't describe, blurred vision. One minute you feel like you need to put your glasses on, and the next minute you don't need them, and you kind of go bouncing back over and over all day long with that, or some days are worse than another. You could have a chronic cough or chronic sinus problems, shortness of breath, focus, concentration, memory issues, disorientation, appetite. We often see a lot of weight gain with people who've been exposed to mold biotoxins, irritability and moodiness, body temperature regulation, tingling, numbness, dizziness, lightheadedness. There's a whole host of symptoms, and they don't always have to be present at the same time. Oftentimes what you'll see is these symptoms kind of come and go randomly, and it doesn't necessarily come with an exposure. Many people are aware of chronic fatigue syndrome, or it's also called myalgic encephalomyelitis. So this is just a big term for inflammation of the brain. Chronic fatigue for the longest time was thought to be an incident that we didn't know what the cause was. Today we know much more, and oftentimes chronic fatigue is a result of a chronic viral infection, chronic bacterial infection, mold biotoxin illness. Any of those things tend to cause chronic fatigue syndrome. There's a specific virus that's very commonly found in this. Unfortunately, the research is there, but we don't have a way of testing that particular virus yet. But that is a very common virus that is known to cause chronic fatigue syndrome. They're also doing research already today about COVID patients. So people who tested positive for COVID, we suspect that they may end up having chronic fatigue syndrome down the road once they recover. LDN shows some very good benefits in chronic fatigue syndrome in small doses. Naltrexone simultaneously as an agonist effect on the non-opioid receptors, including toll-like receptors that are found in macrophages such as microglial cells. And these are microglial cells in the central nervous system that affect the immune system, and they're activated by a wide range of triggers. So naltrexone is thought to disrupt this process by blocking the toll receptors from becoming active, and therefore inhibiting that microglial activation syndrome, helping with the chronic fatigue. Fibromyalgia is very common. It's been around a lot since the 90s. We know that mostly it affects females, but it does on occasion affect males as well. In our alternative world, we don't believe that the body just creates inflammation for no reason. We believe that there's a host there that's causing that. I can tell you in the fibromyalgia patients that we've treated over the last 25 years, 9 times out of 10, there's something bacterial, viral, or toxic exposure that's causing those fibromyalgia symptoms. So the symptoms are very real, but they're not coming just because there's an inflammatory case. There's something there that's causing that inflammation to trigger within the body. We know that it's the glial activation cells that are involved. So just like we had talked earlier with infection, that glial activation is still present. In fibromyalgia patients, when you do a thermography of their body, you can see their myofascial tissue is very inflamed. And myofascial is the thin layer between the skin and the muscle that gets very inflamed, and that's what causes a lot of the disruption of pain. We will also see a lot of circulatory issues in fibromyalgia patients. LDN has been really great. It's treated and found to reduce the symptoms in those patients by 30% of the population in a study from 2010, which is really great. Most fibromyalgia patients are going to use a dose somewhere between 3.5 and 4.5 milligrams. I have gone as high as 9 or 12 milligrams temporarily with patients with fibromyalgia. And once their pain is under control, we can start to walk them back down on the dosage and get them to that 3.5, 4 milligram dose, which works very well then in helping them with their inflammation and pain. Mast cell activation syndrome is a reactive condition that causes people to have allergic reactions to everything. You'll see a whole variety of symptoms: skin itching, flushing, hives for no reason, itchy, watery eyes, nose running, itching, mouth and throat itching, tickling, tongue swelling, lips swelling, throat that feels blocked, trouble breathing, wheezing. It can get as severe as an anaphylactic reaction, or it can stay very mild. Oftentimes people will have a lot of nausea and anxiety as well. They'll have some intestinal disruption, headaches, dizziness, confusion, tiredness, just a whole variety of symptoms that don't make sense because you can't find a trigger per se. In a study done by Dr. Weinstock, he looked at 116 patients, and 70 of those patients found improvement in a wide array of symptoms related to mast cell disorder. And I picked just a few of them so you could see here some of the benefits. Abdominal pain improved 15 out of the 116 patients. Fatigue improved by 11. Autism improved, restless leg, diarrhea, constipation, joint pain and nerve pain. All of those things tend to improve with LDN. Small intestinal bowel overgrowth, or SIBO, is a chronic bacterial infection of the small intestine, and these species normally are encountered in the gut. However, the presence of them getting into the small intestine is where they become pathogenic. There's prokinetic agents that we can use like erythromycin, but a lot of people don't want to use long-term antibiotic therapy to treat their small intestinal bowel overgrowth. So LDN really becomes a nicer option. And sometimes you have to use both, at least temporarily, but then you can use LDN as a long-term effect to keeping that SIBO bacteria from continuing to come back. Because what we see is we need to treat people with antibiotics 3, 4, 5 times before that bacteria goes away. And when we add LDN to the mixture, oftentimes we don't have to use those antibiotics as often or as for long. There are 3 million people in the United States that have Crohn's disease or irritable bowel disorder with diarrhea, IBD. There was an LDN study that showed up to 80% significant improvement in IBD and Crohn's disease, which is huge because these people typically are left with only steroids as an option for them, and steroids decrease our immune function. And so if we can use LDN instead of using steroids, that's a huge benefit for these people in protecting their bones, protecting their heart, and not giving them a lot of side effects that go along with steroids, like weight gain and swelling and so many other problems that we see with that. There's an internet community called Cure Together that back in January of 2018 actually did a study and showed that their patients rated the most effective out of 48 Crohn's disease treatments for ulcerative colitis as LDN being the most effective. IBS in general can be irritable bowel syndrome with constipation and or diarrhea, or a combination. And so research has also shown that with IBS, it can have a powerful immune modulating effect. And it seems to be very worthwhile to examine the use in patients who are afflicted with either IBS or IBD. At a 4.5 milligram dose, 89% of the patients responded to therapy, while 67% achieved remission in symptoms, according to the American Journal of Gastroenterology. This is huge. To have a medication with minimal side effects, to have 67% remission of a chronic disorder that can be debilitating and cause someone to be disabled, it is an amazing feat to be able to do that. And LDN is amazing in this area. Patients in this study didn't report any serious side effects. No patients dropped out of the study for any reason, which is also very amazing, because you always have at least a quarter, maybe an eighth of the patients drop out for other side effects. So to have a study where nobody drops out is huge. That just doesn't happen in today's age. So in March of 2018, research from a German university showed 74.5% improvement and 25.5% remission in inflammatory bowel disease. So now we're starting to see replicated studies, more than one, showing significant benefits in LDN. This should be getting people to stand up, research, think about it, talk about it, and be willing to prescribe it with this kind of research available. For people with chronic headaches or even migraines, naltrexone has been studied for its immune modulatory and anti-inflammatory effects at low doses. So we know that LDN affects the toll receptors and the microglial cells. When we're looking at migraines or headaches, we're looking at downregulation of the inflammatory cytokines and the immune mediators, interleukins, interferons, tumor necrosis factor, and granulocyte colony stimulating factor. In low concentrations of naltrexone, they can bind to those opioid receptors intermittently, which sends feedback to the central nervous system, helping the body reduce pain. So it can benefit as a neuroinflammatory process. Now, the only problem with using LDN with headaches is if you're using other medications that are narcotics, you may struggle with this if you're only intermittently using narcotics. Now, what I found in small doses, 2-3 milligrams, it usually doesn't inhibit an opioid if you needed to use a hydrocodone or something like that during a migraine breakthrough. You can usually use it quite easily without it causing too many problems and blocking that effect. The biggest thing is you're not going to notice that kind of high feeling that you get from them. Some people don't experience that, but some people really have a problem with that as well. LDN has also been used in cancer, very specific cancers, especially multiple myeloma, lymphoma, Hodgkin's disease, breast cancer, cancers of the GI tract or pancreatic cancer, and even lung cancer. There's been studies from Dr. Bahari that noted a connection between endorphin deficiency and various types of cancers. So using LDN in these cases can be helpful for a variety of things. When we're dosing low-dose naltrexone for illness, what we typically will recommend is that people dose LDN at 0.5 milligrams to 1 milligram to start with, go slow and work up slowly to an average of about 3.5 to 4.5 milligrams. Some people need a smaller dose, some people need a larger dose. It really depends on the severity of their immune system. And what we find clinically is some people whose immune systems are really trashed or depleted need a smaller dose for a longer period of time. I have some patients that cannot even work up to a 1 milligram dose. That's just too much for them. They can't do it. But they feel good and they're not having an inflammatory response. But if they try to go above that, they have too many of the negative side effects. And so we just keep them at that 1 milligram dose, and they seem to do very well with it. I do have, like I've said earlier, some patients that I've gone up to as much as 8 or 12 milligrams of LDN. In fibromyalgia cases, primarily. I have not gone up that high in autoimmune cases. I haven't needed to, but fibromyalgia is one of those things where the nerve pain can be so intense for people that we have to use much higher doses. And in that case, we do that temporarily. So maybe 3 to 6 months and get their pain under good control, and then start to slowly walk them down. So much like we would walk them up in the dose by going up a 0.5 milligram or 1 milligram, we'll bring them down in that same step pattern. So they'll come down by a 0.5 milligram for a week and then come down another 0.5 milligram and just slowly come down until they feel comfortable at a dose or they start getting symptoms. And if they start getting symptoms again, then we have them go back up and hold that dose for a little longer period of time before they try to come back down again. So there are common symptoms that you'll see with LDN. They're not terribly problematic, but they can disrupt people for a little bit. The biggest one that we see is the disruption of sleep. So oftentimes people will get disruptive sleep because they get very vivid dreams. And those vivid dreams feel very real, and it makes them feel like they're awake all night long. Now, if you were to track their sleep with a Fitbit or some kind of tracking device, you would see that they're asleep, and most of the time they're in deep REM sleep. It's just that the dreams are so vivid that they feel so real, and that's what makes them feel like they're not sleeping so much. But what we've found is that if we move their doses to morning, it wears off long enough that it's not as disruptive with their sleep. We also find that if people can deal with that symptom for just a couple of weeks, oftentimes their body will get used to it and they'll no longer have that side effect, and they'll be able to tolerate LDN quite well and quite easily. Now, there's some new studies going on with people using LDN for weight loss, and they're using relatively high doses, about 18 milligrams total a day of LDN, and it's split into 2 doses. So you're going to do half a dose twice a day, and it's mixed with oxytocin, 40 milligrams. So you do the same thing. You split both of them and take half in the morning and half at night. And the concept for this is that the weight gain can be an inflammatory response, and oftentimes we see that in patients who are sick with chronic illnesses. They'll have a lot of inflammatory weight gain. They'll have an abrupt 15 or 20 pound weight gain over the course of a month or two. And if we can get that inflammation under control, the weight can start to come down. The oxytocin is put into that mixture to affect the pleasure center of the brain, where the brain makes dopamine. And if the pleasure center of the brain is directly, if oxytocin is put directly to that part of the brain, you won't crave foods as much. And so the cravings for sweet foods or salty foods or comfort foods significantly decreases as a result of using this LDN oxytocin combination. We've used it in our practice, and I will say at this point, I'm seeing relatively mixed results with it. I see some people who it does really great things with, and some people haven't had a change at all. It's like any weight loss thing. For some people it works very well, for some people not so much. But I think it's worth a try in those patients that have had a significant amount of weight gain over a short period of time, simply because they're chronically ill. Now, transdermal LDN is a little bit newer to the scene for things. And there was a Dr. McCandless who has been studying transdermal LDN and delivered it to autistic children with very positive results. And this is a great option. So for people who can't take pills, or they're struggling to get them in, like an autistic child, a transdermal option is really beneficial and helpful, because a very small amount can be applied topically to the skin, and it bypasses the liver. And so we see less digestive system complications, or less side effects of, say, even the dream state that happens by using it transdermally. Now, Because that LDN does not go through the digestive system, it enters the bloodstream immediately. So it can reach those target tissues without being exposed to the degradation of the liver enzymes itself. So naltrexone converted to its primary metabolite, which is naltrexol, at a much slower rate than that being measured of an oral administration. So this is a really nice option for people who are extremely sensitive to things. Our mast cell patients are very, very sensitive to things and oftentimes are unable to tolerate anything orally. And so if we can give them a transdermal LDN that bypasses the liver and bypasses the stomach, they can oftentimes tolerate a larger dosage this way. Or even people who are really sensitive and we're trying to get down to, say, 0.2 milligram dosing, that can even be too much for people. And so using this transdermal benefit can open the door to use this on people that normally couldn't use it in the past. So I'm really excited to see that there's some good research that's available. Now, so far, the research that's been done on transdermal naltrexone has been primarily done on the conventional naltrexone for addiction. But it's very easy for us to take that research and convert it into how low dose naltrexone would benefit people and use that research to our benefit and use that research to help our very sensitive patients. So one of the questions that we're often asked is, can I try LDN for my health condition? And because naltrexone is commonly distributed and used in high doses, you would want a compounding pharmacy to make your product. And like Monica said earlier, I've known Monica a very long time, over 15 years, and I've known her dad and worked with her dad for about 25 years now. And having a knowledgeable pharmacist on your side as a practitioner and as a patient is such a tremendous benefit to us, because when we run into struggles with patients and we're trying to have something created very specifically for that patient, having a knowledgeable pharmacist that understands the literature, understands the research, and can make us a clean product is an enormous tool that we could not live without in our practice. Especially for people who have a lot of sensitivities, like our mast cell patients or our allergy patients, or even if we were to look at patients with genetic difficulties like a COMT or a CBS genetic mutation. And these people you can identify quite easily because these are the patients who will tell you they don't tolerate anything. Even one Advil causes them to have problems, or they'll tell you that if you were to give me the normal dose, I would be really sick. So whatever you would give to the normal patient, I want you to give me 1/4 of that dose. These are the people who have those genetic mutations. And if they have those genetic mutations, you have to get very creative with prescribing for them. Oftentimes, they can have difficulties or sensitivities to different fillers. And MD Custom and Monica's team have been amazing help for us in finding fillers that people can tolerate so that they don't get a side effect from the binding agent that they use to make medications. And a commonly used filler that Monica has helped us with is a probiotic, or even using something like an olive oil base. Any of these kinds of things with a knowledgeable compounding pharmacist can be created for the patient so that they can tolerate a medication. And find different delivery systems, a transdermal delivery system, or maybe you need a delivery system that is in a lollipop or something like that. It's not every medication that can be compounded that way, but when you have something that you need that creativity, you really want a compounding pharmacist who's been doing this a long time, primarily somebody who only does this or has a staff that only does this, because they're the ones that are vested in finding those alternatives for you. So what I would encourage you to do is, if you have a chronic illness, any of those ones that I have mentioned before, an autoimmune disease, chronic symptoms that you're not even sure what the diagnosis is yet, because maybe somebody hasn't found it for you, I would encourage you to have a conversation with your doctor about using low dose naltrexone. If they don't know what that is, or they're not comfortable prescribing it, then I would encourage you to reach out to a compounding pharmacy that makes LDN, and they can connect you with a local practitioner who's prescribing. Now, oftentimes they may not know if that physician, how knowledgeable that physician is, but they know they've had prescriptions. But ask the pharmacist for a referral to somebody who prescribes LDN quite regularly. That will be a good bet for you. And the resources that you were given in the previous lecture of the list of practitioners who prescribe will be extremely helpful for you. The other thing that I always recommend patients do is, if you find a practitioner who's prescribing LDN, when you call to make your appointment, do a little bit of an interview intake with their staff. Now, oftentimes you're not going to be able to talk directly to the practitioner. That's just not feasible, because they're busy seeing clients during the day. And if they took every interview call, they wouldn't have time to treat you as the patient for the illness that you have. However, their staff should be extremely knowledgeable. Their nurses should be knowledgeable. Their front desk staff may not know as much, but you could always ask to talk to one of their nursing staff and ask a few basic questions, like, what is the philosophy of the practitioner in prescribing LDN? How often do they do it? What do they prescribe it for? How many patients do you have on LDN? What has been your experience with patients on it? Have you had good success or bad success? If you ask them for statistics, they're probably not going to know. Most doctors don't keep track of the actual stats in their office. Like, I have 100 people on LDN for this condition, and this many of them are better. We don't have time to track that kind of thing, but we can tell you what our experience is. We can tell you what we see commonly every day. And that should be able to give you enough information to know whether or not the person that's prescribing for you is actually knowledgeable or prescribes enough LDN that you would be comfortable talking to that person. Now, sometimes you can't find that in your area, and you have somebody that's just willing to prescribe for you. And I think that's great. If you have a practitioner who's willing to prescribe, but maybe they're not as knowledgeable as one of the practitioners that you've seen on this forum and this summit today, if you can find somebody who's willing to prescribe, and you could get a good relationship with your compounding pharmacist, like at MD Custom, Monica and Dan are amazing, and they help patients troubleshoot all the time. And they can help you identify whether or not you should go up or down. Now, they can't change your prescription for you, but they can encourage you and give you information to talk to your provider. And they can also reach out to your provider and say, hey, this is what we're seeing from your patient. Could we make a recommendation, and would you be willing to do this with the dosage? And most practitioners who are new at prescribing compounded medication are very grateful for those kinds of recommendations from a experienced compounding pharmacist, because they're still learning as well. And we have to remember that in medicine that's on the cutting edge like this, we're all still learning. Every single day we're learning new things. Look at COVID. We're learning every day about this. I will also give you a little bit of information about COVID and LDN. So clearly it's too new for us to have any kind of research at this point. What I am seeing clinically in patients who we've treated for COVID, if we give them LDN, it significantly helps them with the symptoms that they're experiencing, especially symptoms that like the fatigue and the muscle pain and the joint pain. It can help tremendously get them over the hump. What we're experimenting with right now is patients who have tested positive for COVID and maybe don't have any symptoms at this point. We are really encouraging them to stay on low dose naltrexone to help the immune system fight this infection and prevent the negative side effects that we suspect are going to come from COVID. At this point, what the research is showing is that people who have tested positive for COVID could potentially end up with a chronic fatigue syndrome, a fibromyalgia type symptom, a chronic viral encephalitis that is low grade but chronic. And so they can feel like they're constantly getting a viral infection. We are also wondering if we're going to see similar things with COVID that we see in the Lyme world, where Epstein-Barr and Lyme share DNA. Viruses have RNA, bacteria have DNA, but they share each other's genetic makeup. We are wondering if that's something that we're going to see. So as a preventative front, what we are encouraging COVID patients to do is actually start low dose naltrexone as early as they possibly can to try to prevent some of those complications from happening down the road. We'll see how that plays out, but we're happy to have LDN in our toolbox for those patients that may have complications down the road with it. So I am grateful to have been on this summit today and to talk about LDN and its benefits and how we see it affect our practice and our patients. And I'm happy to take any questions that anybody has on using LDN in chronic illness at this time, if you have any.
All right, Deb. At this point, we don't have any questions, but we'll wait. Okay. We'll give you guys a couple minutes.
Okay.
Thank you for sharing all that information. It was really interesting to hear about the implications with the immune response and COVID and what's still to come possibly with like chronic symptomology with that infection.
Yeah, absolutely. You know, it's only been what, 8.5, 9 months that we've had to follow people. And what we're seeing anecdotally, just talking to patients, is that many of them that had that severe fatigue with the onset of COVID, 6-7 months later are still struggling with that chronic fatigue syndrome. So we do suspect that there's going to be some lingering problems. The problem is we don't know who's going to have them and who's not.
Yeah.
So there's going to be a lot of unknowns for the next couple of years with this infection.
For sure. I had a question with you talking about the use of LDN with weight loss, which is a really interesting and pretty new application.
Yeah.
And you mentioned about the role with inflammation and weight gain. I was curious as to whether you've followed C-reactive protein at all to see if, just curious.
That's a great question. I haven't done a before and after C-reactive protein. Now, when we test C-reactive protein in our patients who have Lyme disease or chronic illness, and we put them on LDN, and then we retest C-reactive protein down the road after we've done other treatments along with LDN, we do typically see the C-reactive protein go down in those patients. The question is it LDN? Is it a combination of all the other things we're doing? It would be an interesting study, though, to look at those weight patients and see if their C-reactive protein is elevated. And then if we give them just LDN for that, if their C-reactive protein would come down.
Yeah, or I was thinking if there's a correlation, because you said not everyone responds, whether it's the correlation with how elevated CRP is.
Yeah, that would be an interesting study to just kind of track people and see how they do with that. And if we can identify, there's no real identifying measure as to who's going to respond to it and who's not. It's one of those things that's trial and error, but I definitely think it's worth trying. Even if you don't notice a significant amount of weight loss, the other upside benefits to oxytocin and LDN are so beneficial and positive that it's worth a try for it, for sure.
For sure. Right. Right. Even on this side is the pharmacist, and because it's not everyone's response to LDN is like night and day.
Yeah.
It can be really gradual, and you always have that unknown is what's all the good that's being done behind the scenes that you may not necessarily be feeling, because we do know how it functions on the body and those microglial cells and all its inflammation and immune modulating effects that could all just probably benefit from taking it.
Absolutely. You know, we get a lot of patients who will say, I don't know if this is doing anything. I don't feel any different. But like you said, we know what it's doing in the body. And so in the anti-aging world, people are using it as an anti-aging tool, whether they have chronic illness or not, just to prevent age-related diseases, because we know as we age, our cells get bad and they get old. And this is a way of preventing that. But a lot of our patients who say, I don't think it's doing anything, they'll stop it. And within about 4 or 5 weeks, they're calling and asking to go back on it, because they're like, I didn't realize exactly what it was doing until I stopped. And then they notice it. And that happens with a lot of different things that we do. So sometimes it is good to do a challenge to really see what it's doing. But like you said, whether you notice any significant symptoms or not, as an anti-aging tool alone, I would be taking LDN.